but the floor is open for any kind of interaction.
My name is Cynthia, and this is for the family doctor. I'm sorry, I forget your name.
Hurley. Jones Hurley, yes ma'am.
Do you have a sense of how many new mothers are breastfeeding and whether there's a big gap in breastfeeding between, the more rural areas to the more metropolitan areas? I know there's a gap, nationally between more educated, more likely to breastfeed. But it's so clear that the longer and more, exclusively a child is breastfed, it's so clear. It's just like it's clear about smoking now. The healthier they'll be. Of my 4 kids, the 3 that I breastfed were never sick as children and never had any illnesses ever.
It's been a few years since I looked at any of the statistics, but at least 3 or 4 years ago when I looked at them, Kentucky was 49th in the country in breastfeeding, only in front of Louisiana. It's pretty poor. The misconceptions about it, and it is. It's partially, I think, rural versus urban, but it's so much socioeconomic as well. Your more affluent rural families are more likely to have ladies that nurse versus.
Let me just ask something. I was a lay leader, 25 years ago. And one of the things we found was that medical doctors did not, really have all the information to give people. They would say you should try breastfeeding. But that they were also given a lot of material and free stuff from formula companies and all. This may not be true any longer, I don't know. But it was a problem.
Yeah, I don't.
We couldn't get, the doctors to push breastfeeding as much as.
Yeah, I don't.
Or if a mom would have a problem, the doctor would say, hey, just
have any breastfeeding or any formula literature in the office. I was so delighted. I saw a 17-year-old girl from Willisburg Saturday. She was nursing, and she was like 6 weeks postpartum. And people will give it a day or two, and they're like, no, this isn't working out. And then they'll just, stop it. But yeah, it was absolutely wonderful to see a teenager still in high school who was nursing. Since we don't do OB at our office, I don't see a ton of that. A ton of pregnant and postpartum ladies, but the rates here are pretty abysmal.
It's kind of funny. They grow up around farms, but they think they can't breastfeed.
Yeah.
And we're a poor state, but that's very expensive to do.
It's very expensive to buy formula.
To buy formula.
Not to mention the medical costs when the kids get sick.
And then they're also confounded by the fact they can't lose the 35 pounds of baby weight.
Yeah, exactly. Well, and that you said that can help with losing baby weight. In our experience with our doctor, that was never brought up. Nutrition was never mentioned once. To the point that we wondered if our doctor had even been grounded in nutrition in medical school. Never was brought up, but we were given a can of Enfamil to take home, the sample. Mm-hmm. Is that something that is nutrition? When I went to school to get an English degree, I had to take a little bit of science. I had to take a little bit of different things to get my degree. Is nutrition not a required? Is that not a required course of study?
Yeah, we get nutrition.
I don't think so.
Yeah.
Okay.
I think part of the problem is that you get on WIC and they'll pay for the formula. So it's easier for a woman on WIC to get formula.
That's another good subject to promote.
Another public health campaign.
It does work allegedly, though. I mean, they really do promote breastfeeding. They try. But I hear what you're saying.
It's pretty.
We'll go for what's easy.
Yeah, when some of our kids are 5 and 6 now, so it's been a while since my wife was nursing. Some of our friends who have infants now, when they're talking to some of their peers in the community and mention, oh yeah, I'm nursing, they're just aghast at that. You're doing what? That's awful. That's gross. I mean, that's an educational mountain right there.
Yeah.
Anybody else? Elaine and then
you all were talking
Eileen?
about nutrition, and all of you touched on it. I wonder what the level of education is in the high school grade schools and high schools here. My kids are way beyond that, so I don't know what they teach now and how well they teach it.
I don't know either.
All I know is I got in high school maybe a half a semester class in basic nutrition and shopping. They taught us how to go shopping.
Look what they're fed in the cafeteria.
Yeah.
Well, I think Dr. Zellin and I'm Zellin's wife, Lisa, we have a 9-year-old daughter here in Washington County School, and she is learning about health in her classes here, and she has been taught that the food pyramid has been changed, so she is being taught about nutrition, and we also teach her at home as well, nutrition, but I and Dr. Zellin don't believe that it's exactly proper nutrition for them as well in the school, because it's more grains than, say, protein, or usually it should be vegetables and protein and grains and then your fruit at the top. So, it's not as accurate we feel it should be, but they are being taught in Washington County proper nutrition according to government guidelines. So they are being taught in the school about it, because she's talked to us about it.
Just a little thing that's interesting, that you were talking about local food and transportation and all that stuff from sustainability. I had a little bottle of, I told Claire this the other day, I bought a little bottle of Tropicana apple juice. I was having my lunch, and I was reading the label on the bottle, and the ingredients came from 10 different countries. It was unbelievable. That 10-ounce bottle of apple juice had ingredients from 10 different countries all over the globe.
Amazing, isn't it? Elaine had your hand up?
Yes, I'm very impressed with the idea of holistic approach to community integration of the health issues and sustainability. And for about 20-25 years, I've been very interested with the difference between Western medicine, as described by Andrew Weil, and he says, for acute care, go to a Western doctor, but for chronic illness, go with the Asian idea that treats chronicity in a much more normal, healthy, holistic way. And when we talk about the rural area, I've only moved here about 10 years ago, but my biggest difficulty is what you were saying about the lack of integration, because in this county, there are no sidewalks to walk. I live on a highway. I can't ride a bicycle. It's not safe. There are no taxi cabs, and there's no buses. And so we're reduced to private car. And recently, I couldn't drive for about 9 months, so I was really contained.
Yeah.
Several years ago, I developed a strange, rare disease, a condition, and there were no support groups. And recently there's another one, and the nearest support group is in Louisville or Lexington. So when you look at holistic community approach, I think we could do much better with parish nurse programs, which have been around for a long time.
Absolutely, I think that's a great idea.
That are run by lay people who know what it's like to walk the walk. Right. We could do a lot of things that lay people and citizens can do to be sort of like para-carers rather than expect a 15-minute interview with the doctor. There are nurse practitioners that could be much more employed in the rural area. I think that some of this is probably economically connected. So there are creative things that we can do. And the more we talk about it and the more we invest our energies, I think the better we'll serve one another and be a community.
I think the idea of the parish nurses is a great one, because I believe that community of nursing throughout Kentucky is pretty active. I mean, I think they're there. So I do think the faith communities, and we have St. Catherine right there in Springfield. I think they offer a wonderful venue for reaching out to the communities, whether it's people that go to your faith community or not, but the faith communities are already organized in a way that allows them to address issues related to health. So I like that idea. Eileen? Okay, Myrna?
I was listening. I know companies, large companies, schools, things like that, have health fairs. St. Catherine has one. We had one at the Mother House, and then the colleges had one. And my sons were talking about in Louisville that they have them at their workplaces. And I was wondering about us having a community health fair where we could meet healthcare people, all different kinds of disciplines. And I was also thinking, when you mentioned about the stroke people, that someone could represent, have a table for stroke victims or whatever you want to call them, where you can sign your name that I have my husband or my brother or so-and-so has difficulty getting around because of this, and maybe a volunteer organization could come out of that. I think there's a lot of people, like I wouldn't mind volunteering driving one day a week or something like that. I think that can happen. If it's just to bring somebody into Springfield or go to Parkview IGA or something like that, then it could be done. But it could also be education.
It's so fascinating to me. There are thousands and thousands and thousands of people with stroke in Kentucky every year. And so you say, well, where are they?
Well, they can't get out.
Right, right. Exactly. That's right.
So there could be kind of a directory.
I think that's a great idea.
That somebody could check on to see what they needed. Or if the care provider needed to get out and get groceries, somebody could go over and sit. You know, we have hospice for people that are at the end of life, but people that are on long-term care. It would be nice to have someone to lead the caregivers too.
But you bring up a really important point, which is about hospice and how successful hospice has become at serving families at the end of life. A hospice model to help people who have chronic illness or chronic disabilities would really be the kind of model that would work well, where you have volunteers and advocates to support families.
And of course, hospice is partially so successful because it's so well reimbursed. The government pays for it.
That's right, yeah.
And it's profitable.
Right, but if you think about how much it costs for Chuck to go into a nursing home, for Medicaid to pay for him to go into a nursing home, it seems like we could make a pretty good case for trying to shift, and I think there are cases being made, maybe in the new health care reform, for trying to shift some Medicaid monies into community services or community support.
I mean, there is home health, but usually they're, too few visits for too short a span.
Right.
Joyce? My name is Joyce, and I'm a mental health counselor. I've been working in these communities for about 15 years or so. And as you were talking, it seems to me as though one of the models probably to look at is the success in this area of the 12-step programs. There are lots and lots of 12-step programs and lots of people involved in those, which are not costly. They're self-run, and people are highly motivated. It seems as though, for whatever reason, that kind of approach seems to work in terms of bringing people together. And if that kind of model could get expanded into other areas, other areas of care and of mutual support, that might be really something to look at.
Good.
I think about preventable health care, and I think that kind of fits in. I was waiting to hear that term, and it wasn't. I think education was kind of the same as that. And I know that I only go to the doctor when I absolutely have to. I mean, you'll have to drag me to the doctor. And I realize that at that point it's too late. Yet my husband goes and has a physical every year, and so anything that's happening is always caught ahead of time. So that's probably more preventable. And I think that might be people, not just me, but I think people just don't think to go to the doctor until they have to. And so then you're not really being sustainable because you're waiting too late to have things addressed. But it's a consciousness, it's a decision to go and get things before they get bad, I guess.
One of the big things that they're focusing on in rural eastern Kentucky is cervical cancer screening, because the incidence of cervical cancer is so high everywhere, but in eastern Kentucky it's higher than anywhere else in Kentucky. And
Why?
So they're doing, I don't know why. I mean, I don't know, they may know, but I don't know. It's been amazing. The best thing that's worked, this sounds, I'm repeating myself here, but again, is a program that's done through the faith communities, where they are having community health nurses and lay people educated in how to educate people in the community about cervical cancer and screenings, and not to be afraid of getting the screen. It's such an easy screen to get, how it can save lives, and using, but you know, the educational piece, using the right language, speaking in a way that people can hear, you know, being very conscious of, I think people in the community, educating people in the community is the way that people can hear best, rather than having an outside person coming in, somebody from UK descending upon Eastern Kentucky and educating them about what's needed, for example. That has not worked well, but people in the community, educating people in the community has worked well. And cervical cancer screening is just one of many things that you're referring to.
As a bit of trivia, there are 34,000 people in the UK cervical cancer study that's going on right now.
Are you talking about ovarian cancer?
Oh, I'm wrong.
You're probably thinking of ovarian.
Never mind, I got it wrong.
Right, but that is a neat, but it's a neat service, ovarian cancer screening.
That's a lot of people
Yeah.
getting a lot of data from.
I'm in it. How about you? Yeah.
But they won't give me any information unless I have a doctor.
Oh, well, yeah, you do need a doctor.
Yeah, you need a doctor.
We got one.
Is there a doctor now?
He's close by.
Well, as you say, the preventative maintenance, one of the problems about it is that a lot of the insurance companies are shying away from paying for preventative maintenance or preventative care.
Most of them are pretty good.
Some of them are pretty good.
They're getting better.
Pretty good. I mean, Medicare will pay for a welcome to Medicare visit at age 65, and then a yearly visit thereafter.
That's fairly new.
Of your commercial insurers, because when the actuarians crunch all the numbers and see that that they save money by making the employees go in every year and just do a few lab tests and talk to the doctor for a while. There are a couple of the big employers in Bardstown, Tower's one of them, that it's mandatory that they go in for a yearly physical.
Mandatory?
Mandatory.
Oh, that's pretty good.
Wow, they better take that to the Supreme Court.
It looks like.
No, we don't want to do that.
It looks like that would give you a break on your health insurance premium too, if you got a physical.
Are they probably self-insured?
Well,
is that the deal?
Well, I don't know if there's anything punitive done for your rates if all the if you fail the whole checklist. If you're overweight, your cholesterol's terrible, and you smoke like a stack, and I don't know how.
Danville Hospital at one time, when I worked there, had a financial incentive for its employees. And if you qualified by being an ideal weight and was a non-smoker and so forth, you got a discount on your premium.
Yeah, UK has financial incentive
I think
too.
that's becoming fairly common.
Yeah.
Healthcare reform addresses some too, and that's where a lot of the preventive screening is non-deductible for it now. And hopefully there's more coming with that.
Hopefully there's more coming. I think that's really the idea is to focus on
and I'm
wellness.
hearing that frequently. I would hear that for colonoscopy, and some of the screening stuff that we do is okay. PSAs, they're just okay, but we do them. Colonoscopies are good tests. Colonoscopies really save lives, and I've had many folks through the years who said, "Doc, I can't afford it. I got a $2,000 deductible. It counts for my deductible." Mm-hmm. But I've also seen here recently, in the last few years, people, insurance companies waiving the deductible for preventive stuff that's due.
The other piece, you averted to the mandatory word, the other piece that I don't know how we're going to get it done, but a huge amount of education, I believe, needs to happen in this state and in this country about the common good. We call ourselves the Commonwealth of Kentucky. The commonweal means the common well-being. And when people are yelling and screaming that nobody's going to make me buy health insurance, I want to say, where is your sense of the good of the whole? Where's your sense of the commonweal? That if all of us want to save money on our insurance, if all of us want to be sure that there's good health care for everybody, we're going to have to give up a little bit of our individual, I don't like this, I don't want this, I. And I think it's the work of the faith communities as much as anybody to help people to realize that we are not on this planet as individuals. We're here as families, we're here as communities, we're here as states and nations and species. And to think that I always get to do everything I want and nobody's going to tell me violates the very nature of who we are. At least it seems to me that a whole lot of work needs to get done in that area, and it's hard work. It's a hard kind of changing to do.
Well, change is hard. I was just thinking about when Delwyn was talking about electronic medical records are now mandated, and there's still a whole lot of resistance against that, of course, and physicians who are hoping to retire before they actually have to do that, or other people. I mean, I have heard from physicians saying that they're going to retire a little early so they don't have to worry about that. But just what you said, where you already have caught up, you have already identified medicine interactions that were negative for your patients, just like that might never have gotten caught if you hadn't had to really document consistently in your EMR.
Yeah, two of the cases were the patients were taking over-counter medication. Mm-hmm. So the pharmacist never would have caught it.
Right.
And of course the medical doctor wouldn't have caught it because he didn't prescribe the over-counter medication.
I can see where that's important, but I have a real issue. I do have a real issue telling you every drug that I'm taking as a chiropractor. I would have a hard time. As a medical doctor, because you're prescribing it to me. But I just think there's too much information going out. This is not on that subject at all, and I see where you were very helpful, but I have an issue.
Yeah, I'm doing it because the government's asking me to do it.
It's all that big database.
And I use an EMR at the office in Bardstown, and it's great. I mean, it tells you about the interactions, and sometimes they're clinically insignificant, and what you need to treat kind of overweighs whatever risk of interaction you may have. But, it's just nice that you have a little computer that can check all those things that you can't mentally keep track of.
Mm-hmm. Is there a plan, like a master plan for tying integrating all the digital records down the road?
Oh, yes.
Well, I think that is the plan for the EMRs. And the EMRs weren't part of this current health care bill. They were.
It all thought out.
It was all thought out before the bill was actually developed. But, it's become such a huge issue when you have multiple practitioners, you individually, and you can't get your records shared among them. It's just a nightmare. I'm sure Jonas can speak to that more than I can, but it's just, even at UK, until we started moving toward EMRs, I couldn't get my internal medicine doctor called me one day to say, I got this record that 3 weeks ago you were hit by a car. What happened? I was like, well, it was 3 weeks ago. I'm doing fine now. I mean, it's just really interesting. Even in the same setting, doctors aren't able to share because there's not a way.
Cost savings, efficiencies, and just overall cost savings.
Yeah. I think that's the plan. And it surely is, I think, from my way of thinking, it certainly is going to go a long way towards moving us forward in the healthcare arena, whether the bill makes it or not.
Yeah, there's a lot of good things about it, but there's also some negatives if people don't like sharing information. But this has been in place since HIPAA came into effect, which was quite a while ago.
There'll be a lot of things to work out about it because of the lack of a narrative, a good narrative. Sometimes those EMRs they're too rote, and so you might miss some of the. So you type yourself.
Patients talking to me, I'm looking at them, I'm typing.
What does
EMR standard?
Electronic medical record.
I'm sorry.
I'm
sorry, I use jargon.
Like at our office, rather than a paper chart.
Electronic medical record.
You know, everything is on a Windows platform where you have access to all the labs on the flow sheets, all the radiology. We're integrated with our radiology suite next door. All the reports get dumped straight in. You know, where you can just click, click, click rather than thumb through page after page of chart.
And then the other problem they have with paper charts is you can't read them unless you're the doctor who wrote them.
Yeah, that's a problem. That is true.
Never let them read your writing. They teach us that.
That's right after nutrition.
We had time for just one more question.
How do you get employers involved in helping an employee who does repetitive work day in, day out that just completely depletes their physical ability?
That is a good question. I have a few patients that I see routinely because their jobs are repetitive. It's tough on them. And it's tough on me sometimes for a couple of them I have in mind right now because they're fairly muscular. And since being a chiropractor is very hands-on, it's very tough for me to adjust them. And if they don't come see me, they tell me I get really bad. So the best thing I can do for them personally is to educate them on stretching, exercises, and have them come in as often as they need it. As for an employer, the two patients I'm thinking of right now work for Ford, and Ford wants their production, and that's all they really seem to care about it for the most part.
The Japanese culture, and they're very conscious of that. Maybe more so than some of the American corporations, but they have rotating jobs, so they do that on purpose, so they can do one thing a while and they're rotating another job, so they don't continue to do that.
I mean, some employers seem more conscientious of that than others.
Yeah,
Like at Zappos, they do stretches, I know, first thing in the morning, but, you know, the human body is just not meant to do the same thing 1,200 times a day, 8 hours a day, 5 days a week. And, you know, when people come to me with, you know, different overuse complaints, you know, you just kind of put out fires. You know, if the carpal tunnel's bad enough, you send them to the orthopedist. If, you know, the tendonitis in their feet's bad enough, give them a few days off and give them an anti-inflammatory. I mean, you just put out fires because if the employers just, you know, if they have to do that same thing 1,200 times a day, they're going to wear out.
But what's usually motivating to employers is workers' comp. And then if they're self-insured, they have to pay for the insurance.
But they have good lawyers.
Well, they have good lawyers, but I know Toyota, I mean, speaking about the Japanese, they had twice the injury rate of the industry, of the American industry, when they first started out here many, many years ago. Don't quote me on that. Don't sue me on that. But I think it's back to, I think now they're equivalent in terms of the injury rate. So they put a lot of time and effort into bringing people up, physical therapists and physicians, to the plant to really walk through and try to figure out. And they were motivated, I'm hoping they were motivated by the health of their workers, but they were certainly motivated in large measure by their workers' comp and the workers' comp claims and their reputation. So there are industries, I used to work in work conditioning environments. This is where I got involved with Toyota, but there are industries that won't let you come in. They do things like drug test their employees if they get injured, or, you know, they do things that make reporting injuries kind of burdensome to the employee. So there isn't a good way to deal with that except that you hope that their reputation and their financial, their bottom line is injured by what you're describing. Certainly see it. So.
All right. Well, thank you so much, each of you. Dr. Delwin and Dr. Ann and Dr. Jonas. This has been a very interesting conversation, and thanks to each of you who came tonight and for all the participation. The conversation gets richer and richer as we go along. So